So the topic of this video is going to be on general inspection and vital signs. These are the very basic foundations of the medic. Okay, they are very important for formulating a good image or building a good picture for yourself and for when you present to the doc as well. Uh, this is something that you really want to get good at, so I encourage you to start inspecting people, just observing them on a regular basis. Okay? The objectives that I'd like you to take away from this is to understand the importance of accuracy when taking vital signs. The accuracy is so important because vital signs tell us a lot about the patient, if not, everything besides, the objective findings and further assessments. Be able to build a mental general inspection of a patient. We talked about that a little bit already. And ultimately be able to perform proper techniques when taking vital signs, and be aware that once you have good proper technique, you're going to you will every time obtain accurate vital signs, and ultimately you will be successful when it comes to your test out. So your general inspection does go by different names. It's general survey, general observations, your initial observations. These data is very important. Um, it starts right when you meet the patient. Okay, and it's based off of four areas: your physical appearance and hygiene, body structure and position, body movement, and the last one is emotional and mental status and behavior. Okay, so we'll just look at these briefly on one at a time here. Your physical appearance and hygiene, this is very important, especially when we go into the field. We want to make sure that our soldiers are staying clean, so we don't have any outbreaks or communicable diseases. Well, most of those are just come with being in communal living. A lot of them are preventable. You want to note their age, skin, uh, any obvious findings that you see right away. Okay. Body structure and position. You inspect their stature. Um, the inspect their general nutritional status, what you observe. Okay. Are they well nourished and well developed? Are they cachectic? Are they very, very skinny? Are they obese? Tripod position. Are they in some sort of position when you meet them? The tripod position, the fetal position. Do they have good posture? Are they just slumped over? Okay. Body movement. How do they move when you're bringing them to the room or to the exam area? Okay. Are they limping? Do they have an unsteady gait? What limitations do they have? Do they show any evidence of pain? Ease of movement. Are they moving easily, or do they need assistance? Involuntary movements. Do they have any tremors or tics? The tremors would be like those shaking, those uncontrolled involuntary shakes, or a tic, or those quick jerky movements. We do actually have a couple soldiers that have this. Um, for those though, I'm pretty sure that's their normal, or um, it's been taken care of in another setting, and you can ask them, and they'll tell you. Okay. The emotional and mental status and behavior is also important. Um, we want to notice their alertness. Are they alert and oriented to person, place, and time, and why they're there? Okay. Their facial expressions. What are they showing you on their face? What does their tone of voice sound like? Uh, Eye contact. Are they keeping eye contact with you? A really big thing that you want to note in this area is noting their nonverbals, their body language. What are they telling you that they don't even realize that they're telling you? Okay. Most people are not that cognizant about their body language. People that are nurses and medics and doctors and people like that have to they have to maintain a neutral, a neutral therapeutic level of communication. Okay. This is one that is actually very important, and it is worth noting. Is their behavior consistent with their chief complaint? We do get malingerers and people who have laundry lists of complaints, and they come to sick call. You need to get them to hone in on one, and then it's up to you to see how the rest of it all plays into that as well. But we want to know if their behavior is consistent with what they have come to see us for. So measurement of vital signs in the normal limits. This is something that you have to know because the providers like to ask questions whether or not you know them. It's pretty obvious. If you rattle off vital signs and one of your vital signs happens to be a pulse of 128, and then you say the vital signs are stable, be ready to be asked a question. What is the normal range for a blood pressure or for a pulse for an adult? Okay, if you rattle off that's normal, they're going to ask you. So know these ranges, know why what they are, and be ready to answer those questions if they are asked of you. The normal we're looking at temperature, pulse, respirations, blood pressure, O2 sats, and then the sixth vital sign is another one that they're referring pain to. When you do in the beginning of your assessment, it is always good to assess for a pain level because it will help. Pain does affect the other vital signs. Okay, so a good temperature range to know is 96.4 to 99.1. The pulse is 60 to 100. Respirations are 12 to 20. Blood pressure is usually 110 to 139 systolic and 60 to 79 diastolic. And in a couple slides we'll actually look at the components of blood pressure and what those two words and values mean. An O2 sat is usually pretty good if it's 94 to 99%. If it falls below 90, it's going to warrant further interventions and assessment. And when we're assessing pain, just assess it on a 0 to 10 scale, 0 being no pain and 10 being the worst pain imaginable. Keep in mind that pain is subjective for each person. Some people are very intolerant to pain. Others, you can pinch them and then they're in pain for ever and ever, amen. I mean, that's obviously two very different extremes, but it just goes to show that each person has their own understanding of what their pain level is. So it's probably a good idea to say 0 is no pain at all today, no aches, no nothing. And you can say 10, you've been dipped into a pool of lava and it's super painful and it's unimaginable. Generally, if you give an understanding of what you're looking for like that, you might get a better assessment of pain from the patient's point of view. Okay? This next slide is on assessing the body temperature. It can be done in several different ways. However, recognize though that there may be a difference in temperature for the various methods. Typically, we will do an oral temperature. We can take a temporal artery temperature or a tympanic membrane temperature. So temporal artery on the side of the head, the tympanic membrane inside the ear. The axillary right in the armpit. This is where you want to know if this is where you want to be cognizant of a difference in temperature. Usually if you take an axillary temperature, it's going to be 1 degree less than an oral temperature. Usually we see this more on infants and pediatrics and things like that. It's not used a lot on adults. And then of course we can take a rectal temperature. The rectal temperature, however, is it just depends on the situation. The most common one that we as medics would see would be a heat injury. Okay. Assessing the heart rate, we know that that is by palpating the pulse. There are many pulses where you can get uh, that number from, but typically in the clinical setting, we just use the radial artery, and it's the most frequently used. Really, the easiest way to do this is by counting the number of pulsations, and you're counting that for 30 seconds and multiplying by 2. Or you can count for 15 seconds and multiply by 4. Really, you're looking for the amount of pulsations over 1 minute. So if you do your math, that's where you get those numbers from. For those of you who do not know where the radial artery is, it's right, here, over the radial notch, that bony prominence coming out of the wrist. Now, there is another way that we can assess pulse, and it's called an apical pulse. And we will practice this, though you won't be tested on it or anything like that. It is interesting to do. You just have to know how to do it. And it's really simple. You grab a stethoscope, and you find the 5th intercostal space, and you go to the left, and you go left of the midclavicular line over the mitral area. And what you're hearing here is called the apical pulse. And when you do this, you're assessing for 1 full minute. You're just listening to the heart for a whole minute and counting what you hear. If you have any irregularities, you have to go and count a pulse for 1 minute. Okay? So, again, count your pulse, get a rate and a rhythm, and assess its regularity or irregularity, and then continue on. Assessing the respiratory rate, similar to the pulse, except this here you do not want the patient to know you're doing it. You're listening for 1 full respiratory cycle. If the patient knows you're doing it, they will probably adjust their breathing, or you won't get an accurate measurement. So don't let them know you're doing it. A good way that I've always done it is I do the pulse at the same time as I'm doing respiratory, so that that whole minute that I'm doing, half of it I'm doing pulse, the other half I'm doing the respiratory. And what I'll do is I will actually put my hand like on their shoulder, and I'll keep my fingers on their pulse, but once I'm done counting the pulse, I'll just keep that number in my head, and then while I have my hand on their shoulder, because sometimes it's hard to see breathing when they have their whole uniform on. So, you can take your hand on there, and then as, the chest rises and falls, you can count it that way too. Note the rate, rhythm, and quality in the effort of breathing. Normal breathing should be quiet, even, and effortless when sitting or lying down. An example here for you is they have a respiratory rate of 20. They're fast and shallow, difficulty breathing. Okay, so, and then you would get better at it. As you get better at it, you can, if you hear wheezes, you would put that on there as well, or because you can have audible wheezes that you can actually hear. So, these are your basic concepts, and then as we go forward, we'll just build more on them. Keep in mind here, this is just a little bit of knowledge for you, that men are typically diaphragmatic breathers, whereas women are thoracic breathers. Diaphragmatic breathing is really just breathing from the diaphragm and expanding the abdomen, and then the thoracic breathing is expanding the chest wall. So, again, just a little bit of knowledge for you to go along with that. So this is where we get into blood pressure. When we're doing a test, we want to know what we're doing, we want to know how to do it correctly, and we want to know why we're doing it, and what it's actually measuring. Okay, so the answer to the question of what is blood pressure is it is the force of blood against the arterial walls and reflects the relationship between the cardiac output, noted here as CO, and peripheral resistance, noted here as PR. Okay, so cardiac output, an easy way to remember that is that is just simply the volume of blood being ejected from the heart each minute. Okay, the PR, or the peripheral resistance, is the force that is opposing the flow of blood through the blood vessels. And I put a little example here for you as well. When the arteries are narrower, the PR is going to be higher, and you would actually see that reflected in the BP as being elevated. Okay. The components that are involved in blood pressure is the velocity of blood, so how quickly it's moving through, the intravascular blood volume, how much volume we have in the vessels at that time, and the elasticity of the vessels, of the vessel walls. Remember that arteries need to be able to expand and, well, actually all the vessels need to be able to expand and dilate, but the arteries are very elastic, so to accommodate for that pressure. The systolic blood pressure, this is something you're going to want to know. This is the max pressure exerted on arteries when the ventricles are contracting, okay, and they are ejecting that blood out of the heart. So that is going to be your systolic blood pressure. So the ventricles contract, blood is shot out, systolic blood pressure. Alright? Your diastolic, however, is going to be the minimum amount of pressure exerted on the vessels. So this occurs when the ventricles of the heart relax and fill with blood. So the ventricles of the heart are relaxed, they're filling with blood. The diastolic blood pressure is measuring the pressure peripherally, or out into the arteries, away from the heart. So where there's, not that systolic, where it has the blood being pushed out. Okay, it's kind of a little bit of a hard concept to wrap your mind around. You just reread through it a couple times, and eventually it makes a little bit more sense to you. Okay, so easy way to remember these: your first number is your systolic. That's the ventricles are contracting, pushing blood out, which is measuring how much pressure is being put out there. Diastolic, ventricles have relaxed, they're filling with blood, you're measuring the pressure peripherally. Okay? When there's no added extra pressure being put out. Karaktov sounds, I can never say that correctly, but this is a Russian came up with this, and these are the sounds that you're actually hearing when you are taking a manual blood pressure with a stethoscope. Okay. We know that blood flows freely until the cuff cuts off blood flow. So as the cuff is being released, blood begins to flow through again, and so these sounds that you're hearing, this is what they're called, the Karatkov sounds, and they each mean a different thing. They can be a little bit hard to distinguish. However, for our purposes of this task and this skill, is we are concerned with the first and the fifth. Okay? And they represent, respectively, the systolic and the diastolic. Okay? Your first sound, the one that you're concerned with, is a clear rhythmic thumping sound, and it corresponds to the pulse, and it will gradually increase in intensity. Your second sound is going to be more of a swishing sound. The third is a more softer thump than that of the first. The fourth is muffled and low pitch. And the fifth, this is another one that you're concerned with, marks the cessation or the stopping of sound and indicates that the artery is open and there won't be any more sound after it. So, your first and your fifth. And by the way, as you're listening to these, you want to be looking at your sphygmometer, okay? The little thing with all the numbers on it, yeah. Because you hear that first one, that's your systolic. You hear the last one, that's your diastolic. Okay. You will want to pay attention to this slide as well because it does play a role in the work that we do. The factors that affect blood pressure are age, gender, race, diurnal variations, emotions, pain, personal habits, and weight. Um, Obviously, a lot of these are pretty obvious here, but ones that you might not know too much about, like gender, for example. After puberty, females typically have a lower blood pressure because of their menstrual cycle, because they're losing that blood volume at least monthly. Whereas after menopause, it's going to be higher than men because of that lack of monthly cycle. Okay, and then there's other things that play into it too, but that's going to be beyond what we're talking about today. Race, the incidence of hypertension is actually twice as high in African Americans as in Caucasians. Okay. Diurnal variations, what that is saying that blood pressure is going to be lower early in the morning and it will peak later in the afternoon or early evening. Obviously, emotions play a big role in our blood pressure. We don't need to explain that too much. Pain as well. Personal habits, ingesting caffeine, which, you know, get into the habit of asking if they've had any coffee or energy drinks or whatever, because usually our sick call is very near, is very close to breakfast or the ending of breakfast in the morning, and a lot of people get coffee to wake themselves up in the morning or to stay warm, especially if we're in the field and it's a cold morning. Weight obviously plays a big role. Um, Higher blood pressure is going to be found in obese patients as opposed to non-obese patients. Um, And on the other thing too, the personal habits, the ingesting of caffeine and smoking cigarettes within 30 minutes will actually increase the blood pressure. I do encourage going through and getting familiar with this slide as well, the errors in blood pressure measurement. If you feel you have abnormal blood pressure, either a false high or a false low, go through these concepts here and see if any one of them is playing a role here. For a false high blood pressure, you can get it from either having legs that are crossed, the arm is below the level of the heart, the cuff was too narrow, the cuff was wrapped too loosely, deflating the cuff too slowly, okay, less than 2 to 3 millimeters of mercury a second, reinflating the cuff without completely deflating it. This I see a lot in PHAs. We get a lot of people that come through. Make sure you are getting all the air out of that cuff before you go on to the next person. Okay? And of course, failing to wait 1 to 2 minutes before remeasuring. If you do have to remeasure, you need to make sure you put that first blood pressure on there, okay? And then wait a couple minutes, do it again, and then write down that second, because you will. If it's how you're going to be able to note a change. The other thing you want to make sure you note is what extremity you did it on. Either the left upper extremity, which is abbreviated as LUE, okay, or right upper extremity, which is RUE. Alright? A good practice is if it's abnormal on one, you can go to the other one, to the other arm. The other thing is keep in mind if it's someone's dominant arm, because those muscles are that arm is continuously used, that may affect the blood pressure as well. For a false low blood pressure, it can be pretty much the opposite of what was for a false high. The arm is above the level of the heart. The cuff is too wide. You're not inflating the cuff enough, or you're deflating the cuff too rapidly, or pressing the diaphragm too firmly into the brachial artery. O2 sats, this is, there are alternative sites to do it, and that's the toe, the earlobe, and the nose. We get this from the pulse oximeter, and what it's measuring is the amount of oxygen that is attached to hemoglobin in the blood. Typically, stats that are lower than 90% are abnormal. Okay. So this is just a quick test your knowledge here. The nurse obtains vital signs on a 42-year-old male having his annual physical exam. He has no medical conditions, and he says that his health is excellent. His blood pressure appears as 62/40 using an automated blood pressure device. Which action by the nurse is most appropriate? Is it obtain a different cuff and take the blood pressure again? Or 2, take the blood pressure again using the auscultation method? 3, place the patient in a supine position and take the blood pressure on the leg? Or 4, record the blood pressure and continue with the examination? Well, when I look right away at these answers, 4 is not going to be the correct answer, so we can eliminate that. We know that if we have an irregular blood pressure and we have a patient who is in good health and they don't typically have a lot of risk factors for it, we need to reassess. But we're not going to do that having them laying in the supine position, and we're not going to have them doing it on the leg, so we can eliminate that one. And we don't need to obtain a different cuff because the question is not telling us that there's anything wrong with the cuff. A lot of the automated blood pressures have blood pressure machines have a cuff that generally fits most people, so we can eliminate that answer. So that leaves us with 2, take the blood pressure again using the auscultation method. The rationale behind this is that if the machine is wrong, just reassess manually. Okay? It goes back to your very basic principle of assess the patient, not the machine. Okay? Because your patient is what's the most important, not the machine. Okay? The next question here, the nurse records the following general inspection findings on a patient: 41-year-old Hispanic male in no distress, very thin, skin tone slightly jaundiced, disheveled appearance, and appears older than stated age. Patient with flat affect and makes minimal eye contact. What additional information should be added to this general inspection? Is it 1, body movement, 2, family history, 3, estimated size of the liver, or 4, palpation of pulses? When I look at this question here, the first thing you want to do is find out the topic of the question. The topic of this question is general inspection, and what are they actually asking? They're asking for what other information needs to be added. So, we look down at our answers. We have body movement. That's usually a good answer. Family history, that's not part of the general inspection. 3, estimated size of his liver. While this is an objective finding, it's not part of the general inspection. And palpation of pulses, that's not something that you generally inspect or that you see visually when you first meet the patient. So the best answer for this question is going to be body movement. I encourage you here in our last couple minutes, that's all we have for this subject here. Please go back to the subjects of errors in blood pressure measurement, the knowing the normal ranges, and there was something else too. Where is it? What is it? Well, go back to those particular slides. And the factors that affect blood pressure. Get to know the normal ranges, get to know factors that affect blood pressure, and get to know the errors in getting a false high or a false low, okay, for blood pressure. Your test out is going to be, yes, the actual practical skill, but there's also going to be where the examiners are going to ask you questions related to those 3 slides, so get to know them closely, and I will see you all at the next drill in October. See you later.